Welcome to this symposium entitled AF Care Pathways in 2025, From Ablation to Stroke Prevention. This symposium is supported by Boston Scientific. My name is Christian-Hendrik Heeger. I'm professor of cardiology and head of the Department of Rhythmology in Hamburg in Germany. It's my pleasure to co-chair this session with Sandrine Venier, a cardiologist and electrophysiologist at the Center University Hospital in Grenoble in France. We are very delighted to be joined by our expert faculty, Reza Wakili from Frankfurt, Germany, Gábor Széplaki from Dublin, Ireland, and Lucas Boersma from Nieuwegein, Netherlands. At this interactive session, we would like to invite you, the audience, to use the Q&A box which we provided next to this video. We will aim to answer as many of these questions during our discussion. Our aim is to have a very straightforward session, so we do the 3 presentations in a row, and in the end we will do the discussion. I would like to begin with an overview of our learning objectives. So first we will discuss pathway of AF care. We will discuss ablation strategies for persistent atrial fibrillation. We show the latest technologies of integrated mapping with pulse field ablation. We share the results of the option trial, of course, and we will share expert opinion on concomitant ablation and left atrial appendage closure. So with this, let's begin with our first talk, Ablation as First-Line Treatment of Persistent AF, Strategy Concomitant Ablation LAA Closure by Professor Reza Wakili from Frankfurt. Reza, I hand over to you. It's a pleasure.
Thank you. Dear Christian, thank you very much for the introducing words. I have to cover today a little bit more than the usual aspects, the first-line therapy, treatment of persistent, and talk a little bit about the concomitant ablation and left atrial appendage closure, which we just saw a live case on right now. These are my disclosures. I will start to talk about the first-line treatment of atrial fibrillation based on the AF care. I just saw what the guidelines state. Oh, I went one slide. Sorry, goes from first-line therapy of atrial fibrillation. And I want to start what the guidelines state in this context. We see the most recent guidelines, and what we all can appreciate is already the change of the kind of recommendation which we already have. This is a class 1 recommendation for rhythm control. If the patient is suffering from symptoms and there's a shared decision making on which kind of rhythm control, of course, and you see down there, the ablation received the class 1 recommendation as one option for rhythm control. And if you look there at the specific recommendation that catheter ablation is recommended now as a first-line option with a shared decision-making to control the rhythm in patients with paroxysmal AF to reduce symptom recurrence and the progression of atrial fibrillation based on multiple randomized controlled trials. So now the question arises in this context, if we have that, which approach, which technology is recommended? And what we can already say is it's the circumferential pulmonary vein isolation only. We have RF, we have cryoballoon, which delivered a lot of, let's say, data and randomized trials that it's superior than drug treatment. So we have to answer the question, what matters? It's safety, it's efficacy, it's efficiency, and ease of use of the procedure. I just want to point some out, especially the focus on PFA as the most recent technology. We just witnessed how fast and effective this can be applied in a patient treatment. So if you look at the efficacy, this is the first data which we concluded as the manifest investigators. We saw that it's actually pretty effective in paroxysmal as well as in persistent atrial fibrillation. And this was also, I would say, confirmed in another setting, which we already said in the publication of Della Rocca and Europace, comparing all 3 modalities of atrial fibrillation ablation energy source. And we saw that PFA actually came out a little bit better than the others, but this was not a randomized trial. The first real randomized trial, we all know it, is the ADVENT trial from Vivek Reddy presented last year. And we saw that PFA was non-inferior in this first really randomized trial using PFA also for people which never used it before, which is pretty good. And I must say, surprised that it went out so well. But if you look at the sub-data, we can actually appreciate that PFA did better in reducing the AF burden below 0.1%. In this matter, in this forest plot, you can appreciate that PFA was better than the thermal ablation sources, reducing the AF burden below 0.1%. And this sub-analysis also shows that actually this was associated with less hospitalizations, repeat ablations, and cardioversions. With respect to complications, this is the same paper of Della Rocca. We saw that PFA actually was associated with a lower number of minor complications, numerically also total complications. We just recently published altogether this data of the Manifest 70K, and what we could also observe in our cohort of 70,000 patients, we have a major complication rate about 1%, which is actually pretty impressive and states again that this is a very safe method to treat atrial fibrillation by PVI. If it comes to procedure characteristics, also this is the ADVENT trial, we can show, and this is confirmed by all the other observational charts, that PFA is actually associated with a shorter procedure duration and ablation time. And you see that also again confirmed in the Della Rocca analysis. Procedural fluoroscopy time was shorter significantly compared to the thermal ablation modalities. We also performed a meta-analysis with my colleagues Manuel Rodka and Isabel Rudolph, comparing the outcome freedom from AF comparing to cryoballoon ablation with all the available data on PFA, and we come out that it's actually in this meta-analysis was superior PFA compared to cryoballoon ablation. We also looked into the complications, and these are all the complications listed, and below in the lower right corner you can see that also in this context PFA was superior to cryoballoon ablation, and when we looked at all the available data in this meta-analysis. So I can say we think we can conclude that PFA is for sure a very good choice for the first-line therapy if you choose catheter ablation and as rhythm control. If it comes to persistent, actually we have not so many data. We all know where we're coming from. It's STAR-F2, no difference in the different approaches. Nevertheless, there's a new trial coming out, ERASE-AF, 2 years ago. It's really a substrate approach, low voltage, more or less on the posterior wall, but really individualized at the amount of low voltage. And it come out that this strategy was superior than PVI alone. And then another trial just after the ERASE trial was the stable SR3 trial, which did more or less the same. It was an individualized approach, low voltage area ablation. And also in this trial, we could see that this PVI plus low voltage area ablation was superior than PVI alone. That shows that at least there must be a difference, like approaching really individualized low voltage area, which are most common at the posterior wall, which is currently not really strongly, but I think the only thing which is evidence based on that this is an approach which can be superior than PVI only in persistent atrial fibrillation. Is this possible with PFA? There's the feasibility trial from Vivek Reddy, which did that. You see it on the left corner that with PFA, he also did the posterior wall. It was pretty good first year efficacy data with 92% free on AF, atrial flutter or atrial tachycardia, but it's only a low number of 25 patients, but at least the safety was good, so we can say it's feasible. There's also data from Hamburg. This is from Melanie Gunnar-Vardene, which shows it can be integrated in the map. And after the map, you can, with the PFA catheter, with the furrow wave catheter, you can also approach the posterior wall. So it's per se possible. And I also refer to the next talk, which we can see if this is also an option for the new technology, furrow wave NAV. Maybe it might be an option and has to be investigated, of course, evaluated. Now coming to the last point, role of concomitant PVI plus left atrial appendage occlusion. We just saw a case on that right now. Is this concept completely new? Actually, it's not. Let's have a look on the cardiac surgery. And I go back to the guidelines. And we can see here that concomitant surgical ablation is recommended, class 1, for patients undergoing mitral valve surgery or AF. So this is already something which is very, very common in the cardiac surgeon, because if you're already there, just do it because you're already there. It's easy to do. And then the LAAC 3 trial came out where it compared if you're undergoing cardiac surgery, open cardiac surgery, and you have atrial fibrillation, if you, in addition to oral anticoagulation, occlude the left atrial appendage, you have less strokes or systemic atrial embolism, which makes the concept that occlusion of the later atrial appendage, in addition to what you do in the cardiac surgery, is a very good concept. And also this led to a guideline recommendation. You see it here, that if you are there and surgical and you're doing cardiac surgery and you have atrial fibrillation, that you can actually, in addition to the oral anticoagulation, have to close the appendage. So the concomitant concept is not new and is actually practiced by surgeons in a daily routine. So coming to the thing which we just saw on a minimal invasive approach, this is data from the US, just like looking, is it performed, how much is it performed? And they looked at data of the national inpatient sample. It was between 4 years. We had 1,200 combined procedure, and of these, 73 was done left atrial appendage occlusion plus ablation. So it's performed. There's another data from Jonathan Piccini. It's the SURPASS analysis. They looked into it. It was possible. Another 1,300 patient compared to LAA only. I just don't want to go on detail it. It was worked out very well. Implantation success was there. And they compared, of course, the complications, and there were not an increase in complications. But we have to mention the whole cohort was a little bit younger, healthier, but there was no negative sign that concomitant procedure of ablation LAO is bearing additional risk with combining these procedures. This is another study on the procedure duration, and you can see 5 colors. The left one is the combined procedure, then AF ablation only, all then with 3D map, and you see the lower bars is AF ablation only without 3D map, and the yellow one is LAA only. So you see it adds procedural time compared to the really fast procedures, but it seems feasible. It's also DRG approved now in the US, and I think we will see soon the option data from Lucas Boersma, and we can discuss this topic later on. And this, I want to conclude. I think we have a very good tool with PFA. According to the guidelines, first treatment is PVI only, and this can be done with PFA. I think for persistent, it's PVI, and if yes, it's low voltage ablation. If this can be done by PFA, it has to be showed. And the concomitant, I think it's feasible. It has been shown many times. How is the outcome has to be shown in randomized trials. Thank you very much for your attention.
Thank you very much, Professor Wakili, for this great presentation and very informative. We keep the question for the end of the sessions. And I will now hand over Professor Gábor Széplaki from Dublin, Ireland. He will talk about integrated mapping system for PFA.
Can you hear me now? Yeah. Sorry, so thank you again for the introduction and the invitation. So my task is to discuss the integrated version of the FARAPULSE catheter, which is integrated to the arrhythmia mapping system. And these are my disclosures. So I think Reza did a very nice introduction to the topic and to atrial fibrillation ablation. And we are in Dublin are one of the first users of the FARAPULSE system around the globe. And our experience has reflected what Reza just told us. When I started doing the procedures, I was concerned about getting a new system into place, but the results are showing an impressive safety. So in our hands, the complication rate is way below 1%. We are over 1,000 cases with the FARAPULSE system. And as everybody knows, the acute results are quite promising. The procedure time is around 30 minutes if you're doing the procedure with the fluoroscopy aid. But one point which can be improved, and in my mind should be improved, is the fluoroscopy time. If I look into our data, that still averages around 14 minutes, which is a bit too long for a pulmonary vein isolation. So certainly integration of the system into 3D mapping should tackle that question. we have some experience with 3D mapping and visualization. I think in Europe, majority of the centers are doing just fluoroscopy-based procedures. And in our center, we do around 10 to 20% of the cases with the guidance of the 3D mapping system. As it was said earlier, this is doable today. You can use the 3D mapping system. And I think it has some benefits today. It's great for the learning curve to teach people, to show them what they're doing when they are learning a new procedure. And it's also a useful tool if you want to go beyond the pulmonary veins and do some extra applications around the atrial area, or if you want to do a posterior wall isolation. But today, the visualization of the catheter into the system is a bit limited. First of all, you have to use a different mapping catheter if you want to create the anatomy and the geometry for the left atrium. And then, as you can see, the visualization is basically a circular catheter in the majority of the platforms. You don't really see the shape changes related to the device. And what is very disturbing is that the lesion visualization and the tagging can be really crowded. So if you're looking at the middle part of the screen, no matter which 3D mapping system you're using, the visualization of the lesions are not perfect. So certainly an integrated solution was really eagerly awaited by the clinicians and the community, which can tackle the problems I just mentioned. So the engineers in Boston Scientific have improved the mechanical properties of the catheter as well, not just the 3D integration. If you're using the new version of the catheter, which was just approved in the US and hopefully will be approved in the next few months in Europe. So if you use the catheter, you will see that the catheter is tiny stiff. It holds the shape much better. The irrigation part has improved, and the handling part with the steering knob has improved quite a lot. But certainly the most important part of the improvement is the shaft electrode. So the shaft electrode will allow us to visualize the catheter in an integrated form in the 3D mapping system, the RHYTHMIA system, or the OPAL system, how it's named today. The big advantage is that you won't have to change the catheter. You can use one catheter to create your map. To create the anatomy, you will be able to use the same catheter to deliver the lesions, and the system will help you with guiding of the lesions. As you can see, there will be a dynamic shape rendering, meaning that you will be able to see if the catheter goes from the straight form to the basket form and then to the flower form. You will be able to see the different sizes of the basket. You will also have some sort of indication of the contact. So in a flower position, you will be able to see if the catheter is bending backwards. And most importantly, and that was striking for me when we trialed the new system, the field tags which are generated and projected to the anatomy by the 3D mapping system seem to be very, very accurate. In addition to the visualization, you will be able to track the whole workflow. You will know if the system is recharging or ablating, or if it's ready to go for the next application. So let me share you the first impressions in the first in-man experience with the FARAVIEW catheter. We were one of the centers participating in the Navigate PF trial. This was a small-scale study. We enrolled 30 patients in 3 European centers, including Pamplona, Prague, and Dublin. The aim of the study was to get the initial experience with the catheter, certainly safety and feasibility of the use. But we took the time and we collected a lot of information during this study and tried to come up with different workflow recommendations. In the study, we had to start with an Orion catheter first, but for the sake of the time, I'm just jumping that and I'll show you how the catheter works in the real life. So this is a patient with paroxysmal atrial fibrillation, and we are mapping with the FARAVIEW catheter directly in the left atrium. During the study, we experimented with the different workflows, and I think today what will work the best is to create some sort of shell of the left atrium and the posterior part in a flower position. And then whenever you're engaging the veins, you can open up the catheter and mark the different pulmonary venous branches. If you want, you can mark different branches. You can search for the different veins. And in a matter of, I would say, 5 or 6 minutes, the system was capable of delivering a fairly electroanatomical map. Okay, if you're thinking about the pulmonary vein isolation, as the catheter was designed to do pulmonary vein isolation, creating the anatomy around the pulmonary veins and the posterior wall is very, very easy. It's a bit more tricky if you want to create the anatomy at the anterior part, but you don't really have to if you're thinking about a PVI. So if you compare the maps, we go by the Orion catheter and the FARAWAVE catheter. Certainly the Orion catheter has a much better resolution. By definition, the signal quality is much better. But if you're thinking about the goal to isolate the pulmonary veins, in our experience, the FARAWAVE catheter has proven to be quite useful and efficient. And it would only take a few minutes to create that map. And you will see in the next slides that the advantage of creating a map will be the ability to see the tags and to predict the lesions. So this is a nice example when we started isolating the left inferior pulmonary veins. As you can see, the system will create some sort of a halo around the geometry in white, where it thinks that the lesion will be delivered. And if you watched closely the movie at the beginning, the catheter was a tiny bit posteriorly placed, and then we had to move it to the anterior to cover the whole antral region. We delivered the application, and now we are delivering the second set of application in the flower configuration. And as you can see, the catheter and the system will guide the rotation perfectly. The system remembers the last point of the catheter and makes sure that your lesions are in the right place and you're not missing out on the antrum. I think that's the key, and that's the most important feature of the device. And I think today the reason for reconnections and recurrent atrial fibrillation after a FARAPULSE procedure is probably 99% related to the improper rotations. Now you will see it in a split second when we're finished with the flower configuration. We can easily go to a basket configuration, and the same strategy applies. You will see if the catheter is centered within the vein or not. And once you have the right position, you just go ahead with your lesions and finish your workflow accordingly. Now, during the study, we had a bit of a time to experiment with the different workflows, and this is another workflow. So if you wanted, you could create the map and do the ablation at the same time. Certainly that would not be my personal preference, because if you do this is an example of the left superior pulmonary vein. In this case, you're creating a tube, and the predicted lesion will be always perfect by definition. So I think it makes some sort of sense to create a bit of an anatomy before you go ahead with the ablation. But certainly the system will allow the users to choose their best workflows. And as I said it already, if you're thinking about delivering an extra lesion, like in this case, we wanted to cover the antral region a tiny bit more with the flower catheter, then you are relying on a perfect anatomy, and you rely on the system to make sure that those applications are done on the right part of the antrum. As you will see in a split second, I'm just pulling the catheter back a tiny bit to cover that antral part of the left superior, which is often missed, and we are delivering the lesion there. Now, during the delivery, the lesion will turn to a red color. There are 3 different shades of the red color, and if you manage to reach the darkest color, then probably you managed to ablate that area already. I touched this already with the Navigate trial. We could see early that there will be different workflow configurations. My workflow will be somewhere in the middle, the balanced one. We would create a bit of an anatomy and make sure that that it helps to deliver my lesion set. And if you're looking at the post-ablation mapping on the left, you will see the Farawave. On the right, on the Orion, again, certainly the Orion has a much better quality by definition, but in terms of real-life usability, I think you can rely on the Farawave. More importantly, what we've found is that if you're looking at the field tags live, which are predicted by the system during your ablation, they are very, very nicely correlating with the Orion post-ablation map, even visually and numerically as well. And we will present some data on the atrial fibrillation symposium in January about that. To sum it up, our first experience was very positive with the system. If you're using the system, you will get a one catheter, which will be able to do the mapping and the ablation for you. I think personally, I was a bit surprised on how the field tags visually help the procedure, but certainly we will need some sort of trials to prove the improvement in the long-term outcomes. What is quite evident, even after doing only 10 cases, is that the fluoroscopy reduction is quite significant. So I think at this stage, I thank you for the attention, and thanks for the organizers for the invite again.
Yeah, thank you for this great presentation. We will go further since we have the discussion in the end. So now I would like to hand over to Lucas Boersma from the Netherlands. So Lucas, please start your talk.
Thank you, Christian. I hope everybody can hear me. So my job today is to talk with you about the combination of left atrial appendage closure and ablation, which has now recently become an option, I think, which is a nice word to use now, because we now have the outcome of the option trial, which actually compared this strategy. Now, before we go into that, these are my disclosures. I think most of us are aware now that the left atrial appendage is a very prominent cause of thromboembolic stroke in patients with non-valvular atrial fibrillation. And here you see the outcome of two randomized controlled trials that were already performed years ago, comparing left atrial appendage closure to vitamin K antagonists to see whether this could be a good option for stroke prevention. And these two trials were, meta-analysis was done, and these two trials compared the combined endpoint of death, stroke, and systemic embolism, and showed that left atrial appendage closure was non-inferior to vitamin K antagonists for this efficacy endpoint. And indeed, you actually saw in these trials that there was a lower mortality and also lower bleeding when patients were using appendage closure instead of keeping on using vitamin K antagonists. So based on these data, stroke prevention by appendage closure got a class 2B indication in our European guidelines, especially in patients with a contraindication for long-term anticoagulation use. But this is only in patients with this particular situation, and in most patients we still favor oral anticoagulation. Another important group, and that's the group where we perform AF ablation, there's also guidelines and recommendations on the use of anticoagulation after atrial fibrillation ablation. And what we see here is that although patients may benefit from AF ablation, even if they're not completely free of atrial fibrillation in some cases, we need to keep using oral anticoagulation after ablation because we might still have stroke and other unwanted side effects. So the guidelines recommend to keep on using oral anticoagulation. But obviously for some patients, this is not a nice thing to do, to keep on using anticoagulation because it may lead to bleeding. And indeed, if you could combine the ablation with appendage closure, that might be a good indication to get rid of anticoagulation and still have reduced risk of stroke in these particular patients. And actually, this idea is not new, and Reza Wakili already showed you some data on that. We actually published a large registry of 350 patients where we did a combined procedure of ablation and left atrial appendage closure. And indeed, we saw that although at least 50% of the patients were not free of atrial fibrillation, if we combine these procedures, the stroke rates after such a combined procedure were very, very low, about 80% reduction compared to what you would expect. And also, the bleeding rate was very low in this particular population. This is a promising thing that we already saw in registries that were done in this particular patient population with this particular combination of procedures. Now, obviously, this also led Boston Scientific to rethink their strategy on this topic, and they actually designed the option trial, which combined ablation plus Watchman Flex left atrial appendage closure, and compared it in a randomized controlled trial to ablation and the use of oral anticoagulation. And in most cases, this was actually a DOAC, so a new direct oral anticoagulant. So these 1,600 patients were randomized to either of these two procedures, and then they were followed up for 3 years, and there were two co-primary endpoints. There was the efficacy endpoint, which was reduction of stroke, systemic embolism, or death. And there was a primary safety endpoint looking at non-procedural bleeding and comparing this in the ablation group with Watchman Flex, comparing it to the patients that used a DOAC after the procedure. The trial was presented just last weekend at the American Heart Association meeting, and it was also presented online already in the New England Journal of Medicine, so you can read a lot of the details in this particular paper. Now, what happened in this trial? There were 1,700 patients were screened, 1,600 patients in the end were randomized to receive either Watchman appendage closure or DOAC after the ablation. It was a multi-center, multinational randomized controlled trial in patients that were all eligible for atrial fibrillation ablation and that were also all eligible to the use of oral anticoagulants. Now, the appendage closure was successful in almost all the patients. What we, as we know from, let's say, modern appendage closures, so 98% of the patients indeed had a successful left atrial appendage closure. I already mentioned that 1,600 patients were randomized, and in the end, almost 1,500 patients made it to the final analysis of 3 years follow-up. Now let's look at the patient characteristics. These were well balanced between the two groups. Appendage closure versus anticoagulation. The average age of the patients was around 69. 2/3 of the patients were male and 1/3 female. Most patients were white, 84%, and 60% of these patients had paroxysmal atrial fibrillation, which you could expect a little bit in this particular ablation cohort. The CHATS-VASc score, still the old-fashioned CHATS-VASc score, was 3.5, which is an annual stroke rate of somewhere between 4 or 5, leaning towards 5%. And in this study, the appendage closure was done sequentially in 60% of the patients, so first ablation and then later on appendage closure, and concomitant in 40% of the patients where it was performed directly with the ablation itself. Now let's first look at the primary efficacy combined endpoint. So that's the intention to treat analysis of this trial. And what we see here is that the trial met the primary efficacy endpoint of all-cause mortality, stroke, or systemic embolism at 36 months. So Watchman Flex was non-inferior to oral anticoagulation. The event rate was 5.3% in the Watchman group and 5.8% in the DOAC group. And you can see that this clearly met the non-inferiority statistical endpoint. So that's, I think, a very good first strike for appendage closure, that indeed it works just as well as using anticoagulation. If we look at the individual endpoints in this intention to treat analysis that comprised all the total endpoints, you see that among all these endpoints, like all-cause death, unknown death, non-cardiovascular death, stroke, the Watchman appendage closure group was actually always numerically the same or even a little bit lower as the anticoagulation group. So also here, I think for all the individual endpoints, sort of a good non-inferiority profile of appendage closure. If we look at the primary safety endpoint, so that is an endpoint that looks at non-procedure related major bleeding or clinically relevant non-major bleeding. So this is sort of a combined endpoint of different types of bleeding. It does not include procedural bleedings. Then we see that also here, the option trial met the primary safety endpoint. So it was superior to the anticoagulation at 56% relative reduction in these non-procedural major bleedings and the clinically relevant non-major bleedings at 36 months. So this is clearly, it met the superiority endpoint for this safety of the appendage closure group. The secondary safety endpoint was also an interesting endpoint because this included all the major bleedings. And what we see here is that appendage closure also met the non-inferiority endpoint for any major bleeding. So this includes every bleeding of the patients in the trial. And here again, you see that in the anticoagulation arm, the event rate was 5%. In the device arm, the event rate was 3.9%. So clearly it met its non-inferiority goal and its non-inferiority endpoint for safety, secondary safety endpoint. So also here, I think a positive outcome of the trial for this particular endpoint. Interestingly, you could also look at the different subgroups like age, sex, JEDS-VAS score, Hasbulat, and AF type. And among all these subgroups, the outcomes were consistent. For the efficacy endpoint, it was non-inferior in all these, was superior in all these particular, no, my apologies. In the efficacy endpoint, the non-inferiority was reached in all these subgroups. And for the safety endpoint, you clearly see that in all these subgroups, the superiority was met and the device group did better than the anticoagulation group. What you could also look is look at the medication use during follow-up. What you can see in the anticoagulation arm is that 85% of the patients were on instructions for use oral anticoagulation throughout the duration of the trial. And in most of these cases, this was a DOAC. And in most of the DOAC use was apixaban. But that still means that 15% of the oral anticoagulation cohort did not use it completely according to the intentions to follow up. And interestingly, in 10% of the patients in the appendage closure cohort, some of them also used oral anticoagulation somewhere during the follow-up. So that could have led to an influence on the outcomes. For instance, in the patients that were also using anticoagulation in the appendage cohort, there's a little bit more protection against, for instance, stroke. And then, but there's also a little bit more chances of bleeding. Conversely, in the control group, if patients are not using anticoagulation, this may be a little bit less in favor of the efficacy, but it could favor fewer bleedings. If you look at an on-treatment analysis with which was defined as more than 80% adherence to all the medication and all the things that were supposed to happen in these two different cohorts, then you see that even if you look at that on-treatment analysis, you still see that ablation plus Watchman Flex clearly had a primary safety endpoint that was superior. So also there it meets its superiority endpoint, and the other two endpoints, the primary efficacy and the secondary endpoint for safety, also met their non-inferiority endpoints. So despite the fact that in some patients you have a difference in what's actually going on, the on-treatment analysis is always a little bit different than the intention to treat analysis. You still see that also this meets its endpoint for the trial. So I think we can conclude that a randomized control trial that compared ablation plus oral anticoagulation, in most cases a DOAC, to ablation plus Watchman Flex left atrial appendage closure, you see that compared to oral anticoagulation, the appendage closure group is non-inferior for the primary efficacy endpoint, death, stroke, and systemic embolism, is non-inferior for the secondary safety endpoint of major bleeding, but is superior for the primary safety endpoint, which is non-procedure related major bleeding or clinically relevant non-major bleeding. So I think that from this trial, it seems that Watchman Flex may provide us with a safer option for stroke prevention and systemic embolism in patients that seek an alternative to oral anticoagulation. And with that, I'll stop, and we can probably open it up for discussion. Thank you.
Professor, for this really clear presentation. We can now discuss about all the topics. I have just a first question for you, Professor Boersma. Do you think that the number of procedure of appendage closure will explode over the world after this option results, and also the combined procedure AF ablation and closure?
Yeah, thank you for that question. I think this trial is not meant to make the combined procedure or performing appendage closure after an ablation make this explode. I don't think that that is the message of the trial. I do think that in some patients, this is actually a much better way to have stroke prevention than using anticoagulants. Again, for patients that do have problems with bleeding or cannot take oral anticoagulants, you see that many patients stop anticoagulation after a while. Also, patients that have fewer symptoms. I think in clinical reality, many of these patients would want to stop using anticoagulants. And I think that now it is an option to discuss this with patients that really seek an alternative. And in some young patients, it's probably better to use appendage closure because they will be, for instance, they will be treated for life, and they don't have to use drugs to do that with all the progressive problems that can arise with using anticoagulation. With regard to combined procedures, I still think that we need to look at the sub-analysis of the study, which is not yet been done, looking at what the best option is. Is it concomitant or is it sequential that is better? I would probably say that concomitant is better and easier because you only have to do one procedure. I would prefer to do that over a sequential procedure, but that will obviously be determined by many other factors.
I have one question also for you, Lucas Boersma, concerning the concomitant approach. I would also love to do it in all my patients, but it's difficult in Germany currently. But in which order would you do it? Would you do first PVI and then left atrial appendage closure, or first closure and then PVI? So what is your order of the procedures?
Yeah, I think that's also an interesting question. With regard to difficult to do these things concomitantly, in my country there is no reimbursement at all, and still we do it concomitantly because at least a part of the procedure is paid for them. So the economical factors that drive this are obviously different in every country. With regard to what would you do first, I think that in the past there was some concern that maybe after ablation there would be some edema of the appendage and that you might undersize the left atrial appendage closure devices, which could lead to leaks and maybe could lead to less efficacy. I think that maybe with pulsed field ablation, as we have seen today, that may not be the case anymore. I would personally always do an ablation first and then perform appendage closure. Also, for some devices, it's easier to first do an ablation because after you put in some devices, it will be very difficult to do a good ablation of the pulmonary veins if there is a disc or something in the way. So there's also some devices where you really need to perform your ablation first before you can implant a device.
Yeah, I also agree to this. So I also do this order. So first PVI and then LAA closure in my clinic. I have one further question to Reza Wakili concerning his talk on treatment of persistent atrial fibrillation strategies. So Reza, we have not enough data currently, I think, but we have some data on strategies here. So in your center, so what do you do for first line therapy in a patient with persistent atrial fibrillation? Just PVI or anything else? What do you do?
Thank you very much. In our center, we stick accordingly to the guideline that we do PVI only first. And if they come with a recurrence, then we actually consider to do PVI plus, depending on how many gaps we actually observe. If it's just a small little gap in the, let's say, right inferior pulmonary vein, and we observe low voltage substrate, let's say on the posterior wall, then they are very open to close the little gap, but also do the substrate in addition. But our first approach is PVI only.
Okay. So this means for every redo procedure, you are performing 3D mapping and substrate analysis.
That's correct.
Then
That's the implication. Exactly. So if we have a redo procedure, we mark that on our schedule, and it's clearly that this procedure takes longer than the first PVI, and that this includes 3D mapping with substrate analysis. We look for low voltage substrate, and it makes it also easier to find the gaps, in which area are really the gaps, and make sure that we really have a sufficient isolation after the redo procedure of the pulmonary veins. In case we find a substrate and we want to perform a substrate-based intervention, then also the 3D mapping before and after is very useful to really confirm the ablation success.
Yeah, thank you. We do the same here.
Thank
maybe
you.
we can check Q&A. Yeah, Sandrine, you of course ask.
Yeah. Just a question also for Professor Széplaki. Do you think the quality of the activation map of the FARA view will be enough to map a left atrial flutter, for example, if the patient turn on left atrial flutter during the procedure, and to make ablation with PFA?
By design of the catheter, the resolution of the FARA wave catheter is a bit inferior, let's say, to the Orion. But it is capable of mapping a macro-oriented flutter. So I think it's not impossible to do that. We haven't run any cases in our 10 series, but I know for a fact that in the US they've done cases and they were able to identify arrhythmia circuits in the left atrium. And just following on the conversation on persistent atrial fibrillation, you could do the same thing at the beginning of your procedure with the FARA wave catheter. You could try to see if there is a substrate or low voltage area, and maybe that is the breakthrough on posterior wall isolation, because we know that posterior wall isolation is not for everyone, but the device is capable of doing those things. Yes.
Okay, thank you.
There's one, maybe I can just check the Q&A. So in patients with high bleeding risk, do you think that LAA closure is a good and efficient alternative to prevent stroke? I think we answered this question already. So in our opinion, yes. I think I can speak for everyone. Yes, LAA closure is a good option to prevent stroke in these patients. Should we blindly perform PVI? Should we blindly perform PVI to all AF patients, or individualized based on low voltage per mapping? So maybe Sandrine, would you like to answer this question?
I think we have to perform PVI to all AF patients, and after perhaps more, depends of patients, but a minimum for me is the PVI.
Yeah, same here. So because we don't know prior the procedure concerning this, if they are substitute or not. So that's something what we don't know. So that's why I think we should, if we perform PVI, we can do an individualization later on if we do a 3D mapping like Reza Wakili is doing. But for the first two procedures, I think PVI is the best strategy for our patients.
If I may add a comment, especially what Gábor explained, maybe in the future, if you're using FARAWAVE with a mapping and you're able to identify a substrate, and then of course we need trials, but then you would be able have a system which is able to provide a very fast single shot PVI. But in case if you really observe a substrate and I would say data would show that this substrate ablation would result in a better outcome, then that would be a nice feature of having a PVI single shot tool, including into a mapping system, which is able to do a substrate analysis. So I think this is at least the perspective for the future. As Gábor showed, at least then you have all the opportunities open. And if you don't see any substrate, you just go for the veins in persistent, of course.
Yeah, that's a very good point. So there's a lot of data concerning PFA, also on performing FARAPulse procedures on the mitral isthmus or CTI. What is your strategies in your center? Do you use FARAPulse for mitral isthmus ablation in certain patients? Reza Wakili, what is your? Lucas Boersma says no, but Reza, what are you doing?
And not routinely, but we have performed it in some redos. I had just recently a case of CTI, which obviously was very difficult. I treated him like I was the first. It was my first approach, but I was the fourth person. This was the fourth procedure in this patient, always having recurrence of an isthmus-dependent flutter. So what we did is we mapped it, and then we put the FARAWAVE basket there, and I think we finally solved this problem. So in very difficult cases or recurrences, then we already applied it. But I think we did 4 or 5 cases in total.
Okay. And you normally
maybe to add
any spasm or something? Sorry.
What we did is I'm a very scary person. I don't know, it's scary, but I'm always anxious about complications. So I put the coronary catheter in the right coronary artery, and we applied nitro prophylactically to prevent spasm, and I monitored it after. And we don't have any spasm after nitro application in these cases.
Okay. So Lucas, what's your opinion?
Yeah, well, I was going to add that there is some data now from Vivek and Peter Neusel and some centers that have tried to systematically use nitroglycerin in different ways. It's in JAK-EP, I think, and see how you can prevent this sort of spasm. And indeed, there is a way to avoid it, but yeah, probably we need some more sophisticated PFA ways and maybe some changes to the waveform or how we deliver it to make sure that we can do this without getting too much involvement on the coronary sinus. On the other hand, there are some data now that show that there may be some late signs of damage to coronary arteries from PFA. I don't think we actually know, but I think we should be very careful to do this. And I know that the company still does not recommend to do this because it has not really been sorted out well. So I would say that what Reza is showing are very difficult cases where in the end you need to do something, and then you take these risks you take them because you need to do something. But I would not recommend it as something to do on a regular day-to-day basis.
Yeah, okay.
There's histological data.
Sorry?
There was histological data on the coronaries, right? What they observed changes. It was in animals that they looked at histological data. That's interesting.
Yes. Yeah.
Yeah, and there was also just presented at APHRS the data for optical coherence tomography after PFA-based ablation, and they also saw some stenosis of the arteries. So there's a lot of things what we don't know yet. So Gábor, what's your opinion concerning FARAPulse at different areas?
No, that's a great question. I think we agree. The presenters agree. I don't never say never. So I'm not saying that I've never used it for mitral isthmus, but I don't think that the FARAWAVE catheter would be the right catheter to use to block the mitral isthmus. But on the other hand, I firmly believe, and I think there are some nice animal experimental data backing up the PFA lesion on top of a pre-existing scar or PFA on top of an RF lesion might be helpful in some situations. And as I said, I don't think that the FARAPULSE system is the right platform, but other catheters like the small basket catheters, which can map and ablate at the same time, might give the right solution for this question.
Yeah, thank you. Are there any more questions? Maybe Sandrine.
No, I don't see another question of the Q&A. So do you have if you don't have any more question, this brings us, I think, to the end of this symposium supported by Boston Scientific. And I would like to thank all the colleagues, Reza Wakili, Gábor Széplaki, Lucas Boersma, and of course my co-chair, Christian-Hendrik Heeger. And thank you for joining us and see you.
Thank you very much. Goodbye.